Ladies and gentlemen, our last speaker for this session is a founder member of UKIP. She joined as one of the very first members of UKIP in 1993. From the Labour tradition, she has subsequently worked within the European Parliament and in 2014 became our second South West MEP. And I'm delighted to announce that although she was appointed science spokesman last year, she was yesterday additionally given the portfolio of welfare. Please welcome Dr. Julia Reid.
Good morning, ladies and gentlemen. As many of you may already know, I'm a research biochemist by profession with a PhD in pharmacology. And before becoming an MEP, I used to run the Diabetes and Lipid Research Laboratory at the Royal United Hospital in Bath. Prior to this, I had worked in the same laboratory on a number of occasions, first as an undergraduate on a 6-month placement, and then as a graduate. On each occasion, I was working for a consultant endocrinologist called John Reckless, whose son, Mark, all of you know, under the supervision of the University of Bath. During this time, Dr. Reckless conducted a number of commercial clinical trials and used the monies raised from these to fund academic research whereby registrars and postgrads could conduct research towards gaining an MD or a PhD. The first academic research I was involved with as a postdoc was comparing the effect of 3 drugs for the treatment of type 2 diabetes: pioglitazone, metformin and gliclazide, which at the time was one of the most widely used drugs for this condition. This was just as the results of the UK Prospective Diabetes Study, or the UKPDS as it's known, were published. This study ran for 20 years and investigated a number of glycemic therapies in diabetic patients. The study had thrown up a number of surprising results, one of which being that patients taking metformin, an old, unfashionable drug, had been found to have a decreased risk of diabetes-related death compared with the conventionally treated patients. Dr. Reckless, who at the time was the principal investigator for a commercial trial involving pioglitazone, approached the manufacturer who agreed to fund our study. While studying for my PhD, I had worked with a research group that at the time was at the forefront of cytokine research. So as well as investigating the effect of the 3 drugs on lipids, we decided to look at the effects on cytokines as well. Our research showed that not only did metformin, an old, cheap drug, have beneficial effects on lipids, I have the paper here, it also decreased the level of inflammatory cytokines that are associated with cardiovascular disease and myocardial infarction, and conversely, the inflammatory markers in those patients randomized to gliclazide had risen. So, why am I telling you this story this morning? The reason is that this type of clinical research, which is never going to be conducted by a pharmaceutical company because there's no money in metformin, is virtually impossible in Britain today because of the European Union's Clinical Trial Directive of 2001. Prior to its implementation, it was relatively simple for medical researchers in academia to conduct the equivalent of phase 4 clinical trials, which are conducted once a drug has been granted a license. These enable researchers to establish the long-term risks and benefits of a drug once it has been introduced into clinical practice, and to investigate parameters such as cytokines, which may not have been known about when the drug was initially launched. Such small-scale studies can be extremely informative, and I'm proud that the renaissance of metformin has a lot to do with the research that we carried out between 1999 and 2003. The implementation of the Clinical Trials Directive, however, has made such academic research virtually impossible due to indemnity insurance, which is astronomical and, in my opinion, unnecessary for a drug that has already been used in clinical practice. This also has two knock-on effects. Manufacturers who were happy to contribute a few £1,000s towards academic research now shy away from the hundreds of thousands of pounds that now have to be added to any study for the bureaucracy of insurance. Academic institutions as well that are happy to host such research on the authorisation of a physician now are too scared of litigation to do so. EU legislation is not only causing problems for academic research in the field of diabetes, but also other areas such as cancer. Anyone listening to Radio 4's PM programme on Thursday evening would have heard Professor Angus Dalgleish, who is based at St George's Hospital in Tooting, saying how his academic research had been brought to an abrupt halt by the implementation of the Clinical Trials Directive. During that interview, he said that he had been so shocked by the effect of EU legislation on his research that he'd begun to investigate the EU itself, only to find that the European Commission, with the aid of the European Parliament, were responsible for a plethora of unnecessary legislation brought into force by lay people who had no expertise in the fields in which they are legislating. This was one of the reasons Professor Dalgleish joined UKIP, and on Thursday was putting forward the case for Brexit on the radio. Confirmation of these findings, an impact assessment conducted by the European Commission has found that the biggest decline in academic trial activities has been seen in the UK. Such a decline, which severely affects drug innovation and development, has undoubtedly had a detrimental effect on the pharmaceutical industry as a whole, which makes a significant contribution to the UK economy. As for the commercial trials conducted by diabetes and lipid research at the RUH, by the time our clinical research coordinator had battled her way through ethics committees and other associated bureaucracy, the drug company would have already recruited the majority of its patients from countries outside the EU, such as the USA and China. The European Commission have woken up to the devastating effects of their legislation, as their own research has shown that there has been a severe decline in the number of clinical trials conducted in the EU. They fell between 25% between 2007 and 2011 as a direct result of this directive. Many pharmaceutical companies are preferring to conduct their clinical trials in countries outside the European Union, such as China and India, which are, of course, unaffected by such draconian legislation. As a result, the European Commission has brought forward new legislation, the Clinical Trials Regulation. And I'd like to think I had a part to play in this, as I was able to make a professional contribution at an open debate on clinical research in Europe that was held in the European Parliament. So, will there be an improvement in the situation as it is at the moment? In my opinion, there won't. The problem is that on so many occasions, the initial proposal from the European Commission, in itself bad, will have been made far worse by amendments tabled by MEPs who have no expertise in clinical research whatsoever. The only advantage to the UK will be that, as this is a regulation, not a directive, all 28 member states should be affected equally, and Britain should not be as disadvantaged as it is at the moment when compared with the EU 27. So, speaking as a pharmacologist who has been involved in clinical trials, both commercial and academic, I know how important clinical trials are in pharmaceutical development, and this whole process is fraught with difficulty, and some of the drugs we use today, such as aspirin, would be unlikely to get approval. Imagine all that difficulty without having all EU legislation as well. So you can see why companies are moving out of the European Union to emerging economies like India and China. So what can we do? What can the UK do to improve the situation? It's simple. On the 23rd of June, we can vote to leave the European Union. Perhaps it will enable clinical research to once again thrive in the United Kingdom.